Hi guys, we are here talking to Rachael Lopez, the clinical research dietitian at the NIH. And we are having some difficulty bringing her in, but we're going to try this again.
Okay, we just hit the invite button, Rachel.
Oh, we got it.
Oh, there we go.
Oh, okay.
Awesome. So I kind of skipped over our introduction. I'm Taylor. This is Polly. We're Beaten Jeans, and we're sitting down with Rachael Lopez from the NIH, the clinical dietitian. So welcome. Thank you so much for joining us.
Thank you for having me today. It's good to see you guys.
Good to see you too.
We have one really important question to start us off.
Yeah. Sorry to put you on the spot like this.
How do you spell dietitian?
So there's two ways to spell it. There's Dietian or CIAN. Most people do the two T's, not.
Okay.
It looks so weird.
It looks really weird. Like, is that right?
Yeah.
So how are you today?
Well, how are you guys?
We are
Good.
good. So we just kind of want to take it back to the beginning. How long have you been a nutritionalist?
Since 2004. So I've been at NIH since 2007, but I got my RD in 2004.
Awesome. And how did you get involved with the NIH?
So to become a dietitian, you have to do a year of supervised training that they call a dietetic internship. Like doctors go through residency and fellowship. Dietitians need their undergraduate degree, then need to go through supervised training for at least a year before they're eligible to sit for the board exam. So I did that training at NIH. I went on to get my master's and worked full-time while I was getting my master's at a hospital in DC. And right when I finished my master's, there was a job opening here, which is not very common. People come here and they stay here for a long time. It's a great work. So I applied and thankfully got the job, and I've been here ever since.
Awesome.
Are you from Washington, D.C.?
No, I grew up in Pennsylvania.
Okay, not too far away then.
Far.
Now your specialty is oncology nutrition. So you work mostly with like gastrectomy patients, or are there other branches that you deal with?
I used
my cancer.
Surgical oncology, all of it. There are now 3 surgical oncologists here, Dr. Davis, and then 2 others, and their programs have grown tremendously in the past few years. So it's too much for one person to cover. So now I primarily cover Dr. Davis's patients, almost all people either with gastric cancer or CDH1 or hereditary gastric cancer syndromes. And then I also cover one other of the surgeons to do other cancer, GI cancers, I should say, but not limited to gastric cancer. But I would say 90% of my patient care time is total gastrectomy.
Okay. Well, there's a lot to it, right?
So when you were going through nutrition school, how did you fall upon oncology?
That wasn't the plan. My master's is in public health, but in maternal and child nutrition and maternal and child health. I was going to go on to do preconception and prenatal nutrition care, healthy babies, healthy kids. And when the job opening became available here at NIH, it was on oncology. And I really enjoyed my time here at NIH. It's really a unique environment with people who are really dedicated to the mission. And we have many benefits at NIH that don't exist in what I refer to as the real world, meaning we don't have to worry about insurance and billing and all of those things that limit what we can do in some ways. So I took the opportunity to come back, and I really enjoy working in this field, so I stayed.
Well, we're
And
happy
we are
to
so
have
happy.
you. Yeah, you're incredible. And every single time we talk to somebody who knows you, they have nothing but amazing things to say about you. So you're a big, big contributor to this whole, group of people.
Not even just CDH1, but everybody talks about you. So we're so honored to have you with us today. So we do have a bunch of questions to throw at you.
Okay.
Yeah. First of all, Polly is having her surgery coming up in June. So for someone that's watching this who's maybe considering having a total gastrectomy, are there ways of preparing for it?
Do you recommend gaining weight, working out? Like, should we be upping our vitamins, that sort of thing?
So we do have, or I have a checklist of things that I want to go over with people as they're preparing for surgery. Because we have, I'm not going to call it a luxury, but we have the opportunity to plan in advance, meaning this isn't a car accident or, something that's sudden and you're rushed to surgery. We want to have you in best possible health coming into surgery. The stronger you are, in good shape, meaning your heart is strong, your lungs are strong, that helps with the recovery after any surgery. So we do encourage people to be active. And that's different for everybody. We have people in their teens who are getting this surgery, and we have people in their 60s and 70s getting this surgery. So level of activity is going to differ person to person, but being active. Strong heart, strong lungs, strong muscles, strong bones.
Mm-hmm.
Somebody is very underweight or very thin, we don't recommend gaining a lot of weight before the surgery. That's just more weight that is going to come off. What we do see is the amount of weight loss that people experience is going to be higher if you're heavier coming into the surgery. So if you go out and gain 50 pounds, that's an additional 50 pounds that your body isn't going to be able to maintain after the surgery. And we want to have a slower rate of weight loss after the surgery, because with rapid weight loss, we have, concerns with things like gallstones and other issues. So being at your stable weight, as long as that's a healthy weight, not underweight. We don't recommend crash diets or fad diets or anything before surgery. A big thing for most people to start working on is chewing thoroughly.
Mm-hmm.
Huge change for most every adult. We're all multitasking. We're all doing multiple things while we're eating. And rarely do I meet with somebody who says they chew their food until it's completely pureed every bite before they swallow.
It's awful. It makes me want to gag.
I know.
Oh,
It's terrible.
But we'll get it down.
That's the worst of it. And what about like vitamins and stuff?
So our program here, we check vitamin levels when people come in for their endoscopies, because with a full GI tract, we don't recommend vitamins unless there's a deficiency or a medical reason to take the vitamins. If you meet with a dietitian in most other settings, like general nutrition, they're going to recommend you get nutrients from the food that you eat, with few exceptions. Vitamin D, for example, is a vitamin that many people don't get enough of from the food that they eat. And we can't reliably and safely get it from the sun anymore, especially those of us who are fair-skinned like myself and burn just thinking about being out in the sun. Be protective. But for the most part, we want you getting your nutrients from the food that you eat. Okay. However, there is a deficiency that we identify on those labs. We want to correct that before the surgery. It's easier to correct a vitamin deficiency with a full GI tract than when somebody doesn't have a stomach.
Right. Now, there's stages after you have a gastrectomy. There's 3 stages, I believe.
The phases. Phase 1 and 2.
Yeah.
What can someone expect during phase number 1?
Great. Yeah. So phase 1 is reintroducing solid foods back to the GI tract, but we want it to be in an easy to digest form, meaning foods that take more work to break down. Think the peel of an apple, celery string fibers, corn kernels, nuts. Those foods need to be chewed even more thoroughly, but those foods your teeth are not going to break down to a complete mush before you swallow. Mm-hmm. So however you swallow, that's how the food hits the intestine. And the intestine does adapt with time from surgery. It is amazing what the human body can do. But there are certain things we cannot ask the intestine to do. And to introduce those foods too quickly, meaning foods that are difficult to break down with your teeth and therefore are going into the intestine more intact, cause a lot of symptoms, abdominal cramping, bloating, pain, that we certainly want to avoid in general, but we definitely want to avoid in the first few weeks to months when it's the hardest to eat.
Okay.
It's adjusting to a new way of eating, and we don't want your brain to get signals that eating made you sick.
Right.
So a lot of like blended foods and smooth foods and like soups like that.
Doesn't have to be blended. Things like scrambled eggs with cheese, peanut butter on crackers or peanut butter on banana, soft cooked things like salmon or ravioli that has a protein in it. So real food, not baby food. A lot of people think, do I need to puree everything I eat? As long as your teeth are able to break down food, meaning your teeth are in good shape, it doesn't have to be pureed, but softer textures and easier to digest.
Okay. And now you said the word protein, and that was a big one as far as questions coming into us. There are a lot of people that live out of the country that their doctors don't even speak the word protein to them. And so I know that at the NIH, you guys try to tell us to get protein with every meal. Mm-hmm. And can you tell us like how much protein per, like, is it based on your weight? And why is it such an important nutrient to consume without a stomach?
Great question. So after any surgery, you have higher protein needs for your body to recover from that surgery. So right after surgery, needs are higher in terms of both calories and protein, but it's also very difficult to meet those needs because the portion sizes you can tolerate after a gastrectomy might be an ounce or 2 ounces per what we'll call a meal in the first few weeks after surgery. We do base protein on weight. So we, in medical terms, we think in the kilograms instead of pounds. So it's usually about 1.5 grams of protein per kilogram, but adjusted because if somebody came in who was much heavier and had a lot of extra fat tissue as opposed to someone who's much more muscular beforehand, we need to make those adjustments. Mm-hmm. With time from surgery, the protein needs to recover from the surgery aren't as high, but you still need protein with every meal to prevent the blood sugar spike, which happens with the change in anatomy, because you don't have the same control, whereas the stomach usually has a valve at the bottom that keeps everything in, and stomach churns everything up, and then slowly food goes into the intestine when you have a stomach. After a gastrectomy, when the anatomy is like a Y, it's not exactly a straight chute. The esophagus moves things down, but there's not the same control of food going gradually into the intestine where it's absorbed. So protein helps slow what happens when you eat carbohydrates, which is a blood sugar spike, and causes a blood sugar spike and then a crash if you're not having protein with the meal. In addition, when you're eating such small portions, for an adult to maintain a healthy weight for their height, their frame, they're going to need to eat protein at every of their small meals to get enough protein in over the course of the day.
Mm-hmm. Gotcha. Right. And is there like a minimum amount of protein per meal, or is it just trial and error? You're like, ooh, I probably should have thrown a little bit more in there.
The goal is to get a source of protein at every meal, but when I say meal, I mean anything with protein. And for some people, some of their meals might be 3 bites. And they're like, I need to stop now. And that's okay. It's important to listen to your body that if you feel full, and full after gastrectomy is like, the food is stacking and it's almost like a pressure on the chest because your stomach stretches out. Without a stomach, the food stacks. If you're full, stop. But an hour, max 2 hours later, it's time to eat again. Mm-hmm. So it's hard to give a minimum because portion sizes are going to change. Clearly, people are eating bigger portions.
Right. And is it the same if I were to eat like a cheese stick or an egg or a piece of chicken or some edamame or maybe some quinoa pasta that's protein enriched? Are all those the same as far as protein intake? And the important, like, does it work the same?
It doesn't matter where you're getting the protein from.
Are you asking, I think what you're saying is it doesn't matter if it's a plant protein versus an animal protein.
Right. Or a nut or a...
Yeah. No, as long as it doesn't have added sugar, because the added sugars don't absorb very well, and you're able to chew it enough, and you eat enough to get the same amount of protein in each of those different sources, right? Because to get the same amount of protein in edamame takes a lot more edamame than if you were eating an egg. It's still doable. We just have to be conscientious. It's much more calculated way of going about meal planning and thinking about food than most people did before their gastrectomy, when it was like, oh, what do you feel like eating for dinner tonight? And it's more flavor based or what you're craving. This is more, at least in the beginning, the first several months, up to a year perhaps, of being more conscientious about it, thinking it through. How am I going to get enough protein in the day?
Right. And then, yeah, this brings us to the food pyramid question. Do gastrectomy patients have like their own pyramid diagram?
Yeah.
Like, is it different than the general public?
That is a great question. It is different than the general public. For the general public, we're especially, I hate to say lump all Americans together, but when we're thinking general nutrition, we're worried about people overeating. So top of that food pyramid was things like oils and concentrated fats, because they're high in calories. And if you can eat endless portions and you're adding all the extra oils, whether it's, a healthy unsaturated oil, an avocado, a peanut butter, you're going to get too many calories and develop problems from getting too much to eat. After gastrectomy, we're more worried about not getting enough to eat. So we want more of those oils, the peanut butter, the avocado, that give you more bang for your buck, more calories, more in a small volume, because I'm not worried about you overeating to the point where it's going to cause a problem.
Okay.
It's
So probably
reverse.
like calories per kilogram is bigger for the gastrectomy group. And how much of what we eat is absorbed? Is there like a baseline that you can say, or is everybody different?
So everybody's a little bit different, but it's more how you're eating and what you're eating. Because if you're experiencing what we call early dumping syndrome, where food is moving through you too quickly and it passes through, you're not absorbing that. So somebody who might have a day where they ate something that they didn't realize had added sugar in it, or they ate too quickly, or they ate too much and it just went through them, they didn't absorb ideally that day. But the next day, when they're really conscientious about chewing everything really well so that their intestine can absorb it, and eating small portions throughout the day, ironically, you absorb more by eating less at a time, but by eating more often than you do by trying to make yourself eat large portions at once.
Right. So we can judge how well our food is being absorbed by the way our stool looks.
Yep. So diarrhea, urgent stools, floating stools is a big sign that you didn't absorb. Seeing oil droplets in the toilet would be a sign that you're not absorbing certain fats. Having a formed bowel movement every day is the goal, and a better indicator that you're absorbing what you're eating.
And usually the main culprit to the looser stools is sugar. Is that right?
That's one of the culprits. Eating and drinking at the same time, especially in the beginning, because when it's a volume issue, volume makes the intestine contract, which passes things through. So eating and drinking at the same time in the beginning, before your intestine has time to adjust and kind of figure it out, that can cause diarrhea. Again, eating too much. Remember, there's no way to hold it in. So it's going to make the intestine contract. And not chewing enough, because the intestine can't absorb it. So imagine just the intestine kind of just pushing it through. So there's a few reasons.
That makes really good sense.
Yeah. I want to talk more about the blood sugar drop. So you can't have added sugar, but does that include things like fruit, bananas, and apples, and honey?
Nope. You can have carbohydrates. We want you eating carbohydrates. They just need to be with a protein.
Okay.
Because something like, let's say banana, that carbohydrate in the banana, again, it's going straight to the intestine, And our intestines are designed to soak up carbohydrate quickly. It gives us that fight or flight response, gives us instant energy. But your pancreas still thinks you have a stomach. And when you eat with a stomach, the start of the meal, the food comes out into the intestine, and the pancreas is monitoring your blood sugar and releasing insulin. So when the pancreas sees a high blood sugar, it's going to dump out a lot of insulin, which makes your blood sugar crash.
Right.
So eating that banana with peanut butter or with another source of protein, one, so you get enough calories and protein, but two, so that your blood sugar doesn't spike, prevent that blood sugar crash from I don't say an overreaction of insulin, but more insulin than your body needs for that blood sugar.
Very interesting.
It is. And then we've got questions about gaining muscle. Is this, again, like a protein thing? Like, is it harder for people with gastrectomies to gain the muscle
when they're working out?
It takes more work and more attention. We have people who are athletes, endurance athletes, strength training. We have some people who say they're 2-3 years out plus. Some people who say they're stronger now than they were before the surgery because they're exercising and lifting weights to help their bone density. Whereas before the surgery, that was not something they thought about, and maybe they didn't exercise very often. So it is possible, but it does take, again, good nutrition, attention to the amount of calories and protein you need, the timing of the meals around your workouts to make sure you're getting the protein in right after you've, stressed the muscles. So it is possible.
Okay. So increasing the protein after your workout.
Yeah. So the purpose of exercise, I'm sorry, go ahead.
I'm sorry. I'd rather hear what you have to say.
For most people, and again, nutrition is very individualized, which is frustrating for many people because I can't say for everybody. For most people, exercise after gastrectomy is for the purpose of their overall health, meaning their strength, their muscle mass, their bone density. We want to keep your heart strong, your lungs strong, but it is not to create a calorie deficit, meaning burning more calories, because we don't need you losing more weight for most people. So eating right before exercise, being able to hydrate during exercise, because you can't just pick up like a 2-liter thing and chug it. It's sipping. And then after exercise, feeding the muscle with protein, because when you work out, you get those micro tears in your muscle, which is what you want for that to then grow, but it needs the nutrition to do so.
Do you recommend a certain protein powder to your patients?
That varies too, because I have people who enjoy and tolerate whey-based proteins. I have some people who don't tolerate them or don't use milk protein in their diet for surgery and aren't interested in it after. So there are pea proteins and other plant-based protein powders available. Those are usually not well tolerated right after surgery because they cause a lot of gas.
Right.
And without the stomach to stretch for that gas, the pressure against the intestinal walls is very uncomfortable. But so again, that's something that's individualized. I don't have one product that I say, everybody does this. More varied. And the good news is there's so many products available now on the market.
Okay.
Are you an advocate for like organic foods? Do you think that plays a role? Is that important in nutrition?
That's such a good question. There's so much research going on and more that's needed about organic because there are pros and cons to organic. There are certain things that people worry about for foods that are organic in terms of spoiling and different exposures. There's often also tests that they do for what are labeled as organic crops that still have pesticide residue on them. So that complicates studies to see is something truly organic or is there still residue there. So I don't have enough information in my mind to say definitively everybody needs to do this or everybody doesn't need to do organic. there are certain crops that are labeled the dirty dozen, the dirty 15, like it's changing. And some would argue that at least choosing those foods organically, if that's within people's budget, which is also a concern. I'd rather people eat healthy foods, but if they can't afford the organic, I think there's still a lot more benefit of eating the healthy foods than not eating them because they're not organic.
Okay. Right. Yeah.
Good.
Yeah. We know about that dirty dozen.
Yeah.
One more question about the working out, because Michelle is wanting, it's her birthday today, and that's why I'm going to mention her. Happy birthday, Michelle. She wants to get back into doing Zumba, but her energy level is so low. She's wondering, is it the same for gaining muscle? You're just going to eat before and eat after to help with that energy level?
Yeah, and depending on how far she's out from her surgery, if her weight has stabilized, if she's getting the right nutrients, there are other things that she could look at to see what might be causing her low energy. Not getting enough calories is going to make you feel tired. So in that case, burning more calories with exercise, we have to think about if that would be a benefit at that time. If that's not the issue, and she hasn't had her nutrition labs checked in a while, it'd be a good time to check her iron or possibly other nutrients if she's not taking certain multivitamins.
Okay, good. Okay. And how often should we be getting our labs done?
So our protocol here at NIH, we check them every 3 months the first year, and a minimum of annually thereafter. We can't serve as everybody's primary care physician, so we partner with home teams, and that's something we are working on actively of helping build that partnership for people, because we realize that, you know, we're not discharging people home and expecting their home providers to know everything about CDH1 and management of total gastrectomy. We're still here to manage that, but there are times when if somebody walks into the office complaining of fatigue, it's necessary to check labs because of the higher risk of deficiencies. So again, an individualized answer, but after that first year when we're not checking every 3 months, it depends how people's labs have been trending and how well they're tolerating the vitamins. We put everybody on a bariatric multivitamin and calcium citrate. If they're unable to tolerate that for any reason, they're really struggling with it, so maybe they're not getting it every day, we need to keep a closer eye on labs because it's likely they're going to develop a deficiency.
Okay. And does it matter what type of vitamin, like chewable or capsule or liquid form, or is it just if you can get it in, then that's all that we really care about?
It does matter. Supplements aren't regulated like medications are. So supplements need to be third-party tested to make sure that what's on the label is actually what's in the bottle. We recommend and have everyone on bariatric formulated multivitamins, which are formulated in a way that you can absorb without stomach acid, because many nutrients require stomach acid or intrinsic factor in the stomach to be absorbed. And they're also in doses that meet the guidelines for micronutrient supplementation after the Roux-en-Y, which is that new connection. Those bariatric forms, if it's a capsule, they're formulated in a way, again, you can absorb without stomach acid. But in general, there are concerns about certain meds that are capsule form, pill form, that may not be absorbed. So that's something we have a pharmacist here dedicated to our team who's amazing and reviews everything for our patients, but to be looking at the form of vitamins and medications too. Liquid medications, ironically, can be troublesome because oftentimes they're in a sugar solution or alcohol solution, and then they're not absorbed.
Oh, okay.
So looking at the ingredients, even in vitamins and medications, is important.
And does your mouth also play a role in absorption? Like if we were to chew our gummy or our chewable vitamin and then kind of swish it around, would that be helpful for those people who are still like struggling with bone loss, and just tips to kind of help get that extra that vitamin more absorbed?
Yeah. Breaking things down with the mouth, just like eating, can be very helpful. And again, just making sure if it is a pill or a tablet that it's something that can be absorbed without stomach acid.
That bariatric
Yeah.
verified vitamin. Okay.
Good. That's another big issue is the bone loss. So is that just something that, like, I would think just the calcium citrate is a big helper in that, the nutrition and weight-bearing exercises. Is there anything else that people can do to combat the bone loss?
Sure. Those are 3 big ones. Also keeping vitamin D in the normal range. So there's vitamin D in the bariatric multivitamin and in the calcium, and that's one of the labs that we check. There are many micronutrients involved in bone density, and some of those, the role we don't understand, like we, meaning medical scientific community, don't understand completely yet, but things like magnesium and vitamin K are also important. So it's not just it's not just the calcium, it's looking at the whole picture. We're studying bone density here as part of our clinical research because, we're doing, or I should say Dr. Davis is doing the surgery with the goal of preventing gastric cancer for a long and healthy life. But we know there's risks that we need to be monitoring for, and we want to look more into if there are other things that we can do to help prevent loss of bone density. So that's something we are studying and hoping to publish some things in the near future.
Good.
Yeah, that's exciting.
I know there's all different types of magnesium. Some of them can make you have the run. So is that so gastrectomy patients can take magnesium?
So it's in the multivitamin. It's usually not needed as a separate supplement. High magnesium, you're right, can cause that GI distress that we want to avoid.
Okay.
And does the vitamin pretty much have all the nutrients that we need in a day? Because I know a lot of people with gastrectomy are eating, like, they're safe foods, and they eat the same foods every day, day upon day, and they're not maybe getting all that variety by changing their menu up. Mm-hmm. Is that important? Like, if we were having a bad day, we aren't able to eat. This is another question. I'm running on, but do you know what I mean? Like, is that okay to not eat variety and just eat the same things every day? Are we missing out on all those micronutrients?
Yeah. So we're using the multivitamin to get the micronutrients consistently. In the beginning, I always say our goal is hydration, calories, protein, vitamins. I'm not looking at a wide variety. I'm not talking a rainbow of fruits and vegetables on your plate. Again, it's a different way of looking at nutrition when you're missing a part of the GI tract. With time, that variety comes. So it's usually after the year mark when people are back to clinic with like smiles on their faces and say they're feeling well and they're enjoying eating to some extent. Some people never feel that true enjoyment of food again and eat because they know they need to eat. I can't give you a percentage, but I would say it's not more than half. Other people say they enjoy eating sometimes, but not consistently. So they're still eating because they know they need to eat, not because it's like, oh, I have a craving for what have you. But usually past a year, there's more variety than there is in the first few months.
Does age play a factor in someone's, like you say, like their enjoyment of eating?
I don't see a consistent pattern.
I just wonder if like recovery, like having to do with age, like if someone younger, like a lot of the young people that we've talked to have really no issues. They can eat anything they want. And the older people are the ones that seem to struggle. Is that something that you see also?
No, I would say it really varies across the board. And we have people in their 20s and 30s who have really struggled with different issues. And maybe one issue resolves and then a year later, something else comes up that's bothersome to them.
Right.
It is interesting because it's different life stages too. So somebody in college who might be tolerating eating but can't participate in certain activities that many do in college in terms of parties and things like that, that impacts their quality of life and how they would rate their, you know, the normalcy of living versus somebody who's 60 is probably not going to college parties and expecting to do those types of trips. So I'd say it really varies. And it's hard, it's frustrating because we can't predict at this point going into it if somebody's going to struggle with something like bile reflux or not. We can't say you'll be one who does have a bile reflux and you won't. That's something we don't quite understand yet, why some people get it and some people don't.
So if somebody were having a bad day and they were having the bile reflux and just not feeling well, what would be the most important nutrient for them to concentrate on consuming? Does that go back to the protein?
Yeah, I would say fluids and protein. Protein drinks are a great tool to use to get nutrition in when you either just can't get solid foods in, it's just not working that day. I mean, there are some people who their mornings are really hard and they just can't make themselves eat right away. And some people, it's the evenings, they've been chewing all day and they're like, I don't want to chew anymore. So doing a protein drink, whether it's a homemade smoothie that you make with your own ingredients, there are many on the market that don't have added sugar, but using that as a tool to get in fluids, because again, dehydration is a concern and you can't just turn around an hour later and chug a liter of fluid, but also getting the calories and protein too.
Oh, good.
Does someone without a stomach, can you get like a stomach bug, like, you know, the stomach flu? Can you get that? Do you throw up ever from eating bad food or anything?
You can get nauseous. It's harder to throw up, but it is possible. What most people experience when they're nauseous, whether it's from overeating or if they did get something like they ate something bad, that like excess saliva and mucus, that's a physiological mechanism to protect your teeth from what would be stomach acid coming up, right? So getting that, a lot of people call it the spits or the mucus, or they'll tell me that they're throwing up, and anybody who's worked with me will knows my next question is what came up. A lot of times mucusy, it's spit, it can be bile. If it's food that someone's really full, they can bring food back up. We've had people who have spit up food, but for the most part, I would say it's more they wish they could throw up because they would feel better, but it's not vomit. Yeah.
Okay. Interesting.
Well, that's good. I hate throwing up.
These are all glamorous topics I talk about.
Yeah. Right. Let's see what other questions we've got.
I wanted to know, what is your biggest complaint that you hear from people?
Biggest complaint. Cooking is a big one. Like, I would say the work that it takes to eat.
Okay.
Eating isn't usually work, right? It's something we enjoy. It's something we use for social activities, parties, celebrations, family traditions, coming together with our family at the end of the day and enjoying a meal together.
Yeah.
Eating is just in so many aspects of our life. It's not just, did I get my calories and protein and vitamins today? It's a social experience, and it's typically a pleasurable experience. So when that aspect is not there, when it's the work to eat because you don't feel hunger and you're just eating because you know you need to eat, many people struggle with at least a period of feeling sad about it, feeling a loss of, you know, what it was like before their gastrectomy.
Yeah.
And this is probably a little controversial, but does marijuana help sometimes if people are having a hard time with appetite and maybe the desire to eat? Have you guys? Yeah.
So we can't prescribe it or give a card for it because we're a federal facility, but people do use it at times to help with appetite.
Okay. That's interesting that it would still work, because you'd think it would communicate with your stomach, right?
Yeah. Yeah. I wonder if it's better to smoke it or eat it. I guess smoke it, right?
I have no idea.
We don't want people smoking a lot, but it works brain process to encourage you to eat. It's not like it makes your stomach growl.
Right.
Right. Yeah.
Turn in the brain like, ooh, that sounds good.
Yeah. Okay. Interesting. Wow. Well, I don't know. Do you have any more questions?
I don't think so. Do you? You're the one with the upcoming surgery. Do you have any last minute things you want to throw in there?
I'm sure I do.
When do you start introducing foods after the surgery? How many days is it typically?
4. Dr. Davis does the gastrectomies on Mondays, and we have people on solid foods on Friday, as long as there weren't any, unexpected things post-op.
And what does somebody require a tube feeding?
So somebody would require tube feeding if they have issues where they cannot physically eat. So it's more, I'm going to say it's totally rare. It's less common to have trouble swallowing after the surgery, but we have seen it where it's like the esophagus isn't moving in a normal way, contracting in the normal way to push food down. So food is like going up and down and up and down. That's an example of a time when people could spit up food because it's not going down the way it normally would. So we've had uncommon experiences, but experiences with that where somebody needed a J tube, which is a tube inserted into the intestine for a period of time until that resolved. We've had some people who need a J tube for hydration because they can't tolerate enough fluids and they're just getting chronically dehydrated. Dr. Davis does not put in J tubes like at the time of gastrectomy unless there's a reason pre-op that somebody is not getting enough nutrition and we know that we're going to need to support them with the J tube for at least a period after the surgery. But we use them if and when they are needed.
Okay.
And how do you know if there's a leakage? Do you do is
a swallow testing afterward? But you mean before you start eating?
Yeah.
Yeah. Our inpatient team, many of you who have been here know Stacy Joyce and the fellow and Dr. Davis are looking for specific clinical signs of that. We're checking labs in the morning. We're looking for things like your white blood cell count, for fevers, for any symptoms that would be unusual. And then they would do imaging and a swallow eval if needed, an esophagram. But otherwise, we would just move along. We don't require all of those things before we start giving people at least liquids to drink the Wednesday, protein drinks Wednesday, Thursday, and then solid food Friday.
Okay. Oh, so I was thinking, gosh, I'm going to be hangry 4 days, but you do have protein shakes and
yep.
Okay.
On Wednesday, we now have a clear protein drink that I was able to get on our formulary. So we start that Wednesday, and then a full liquid protein drink Thursday, and then solid foods are available Friday. But most people are doing some solid foods, but also using those protein drinks, again, as a tool to get protein in as they kind of transition to solid foods.
Well, cool. Well, you make it seem so like doable and practical and just concentrating on our protein intake and calories and hydration and
vitamins. Yep. I think we can do that. Check 4 off.
Right.
Yeah. That's doable.
Not going to say it's easy. And it's hard because people come into the surgery having eaten their whole life. Everybody eats, right? And everybody has certain nutrition principles in their head of what healthy eating means. And a lot of that is turned upside down after this surgery. Mm-hmm. And another thing I see that's frustrating for people is they're trying to apply principles that were true or helpful in terms of their nutrition when they had a stomach to now when they don't have a stomach, and that doesn't always work, and sometimes it causes them to lose more weight. They try to eat more than they can, so like if I overeat I'll gain weight and they end up dumping, or if I eat a lot of ice cream I'll gain weight and they end up dumping. So it's a different way of looking at nutrition and trying to at least be conscientious that your GI system is different. And it's amazing that you can go on to live a full and healthy life without a stomach. But we have to look at what is doable and what your body can't do, at least for a period after the surgery, so that you can get the nutrition in a way your body can absorb.
Right. Well,
and in time, our intestines will evolve to where it might absorb the food the way we eat now. In a way.
Intestine adapts to be able to absorb more, but if you don't chew it thoroughly enough, if it's still intact, the intestine is never going to have the ability to release stomach acid to break down food. It doesn't have that grinding function to puree food into a form it can absorb. The intestine is designed to absorb food once it's already broken down.
Mm-hmm.
Yeah. I wonder if we did make like a gastrectomy food pyramid just for a visual so people could see that.
Yeah, that would be helpful.
Yeah, that is a fantastic idea. I have to think about that. That's a really good idea.
Yeah.
Yeah. So I know a lot of people like visual.
Right. Yeah. We should work on it. That'd be fun.
Well, I think that you just gave us an amazing bit of wisdom there about how it's kind of like we need to train our brain to unlearn what we learned and relearn what we need to know now. But do you have any additional bit of wisdom to leave us with today?
I would just say to communicate with your team. For the patients who have their surgery here, we are very fortunate that we don't have to be constrained by insurance. So when somebody has a question, a concern, something's not going well, they call me and we can talk right then and there to help prevent the problem from becoming a bigger issue. They don't have to wait 3 months to come in and talk to us if they're not able to stay hydrated or they're losing too much weight or they're too fatigued. For people who have their surgeries elsewhere, I would say to get connected with a dietitian who has experience with someone who had a total gastrectomy, and to communicate with your team to address issues and difficulties as they come up, because the first year is a transition period and it's difficult. And I see my role as helping people navigate that, knowing that it's very individualized. It's a lot of work, but we want it to support people in that process so that they feel good and recover and are able to get back to the things that they were doing before the surgery to the most extent.
Right. Well, we're so happy that we have found you guys and that we're a part of the team, and we always look forward to our visits and speaking with you.
We
And
feel so lucky to be a part of this study.
We
It's
do.
amazing.
Yeah.
We have amazing friends, and I feel very fortunate to work here and to be able to work with people going through this unusual.
Right.
Yeah.
Yeah. Well, thank you, Rachel. That was so incredible. And I hope that we answered everyone else's questions that you guys gave us. And yeah, that was fun.
It was fun. And I'll see you in June.
Take care.
Thank you so much, Rachel.
Rachel.
Bye.